All right, let me share my screen. Okay, let me put that in slideshow. All right, can everyone see that all right? Oh,
Yes, it looks perfect.
amazing. All right, let me just go back one slide. Okay, well, good afternoon, everyone, and thank you so much for the invitation to be here today. My name is Sunaya, and I recently graduated from Vanderbilt Medical School and will be an incoming pediatrics intern at Stanford in just a few weeks. As a medical student, I had the privilege of working with Dr. Stephen Patrick and his team over the last 3 years, and I'm really grateful to have the opportunity today to share our group's work and the results of our recent paper that was published in JAMA Health Forum titled Buprenorphine Treatment in Pregnancy and Maternal-Infant Outcomes. I have no documented financial relationships to disclose or conflicts of interest to resolve. To start off with a little background, there has been a considerable increase in the number of pregnant women with opioid use disorder in the United States, increasing from 1.5 per 1,000 delivery hospitalizations in 1999 to 8.2 per 1,000 delivery hospitalizations in 2017. This growing crisis is associated with adverse outcomes for both infants and mothers. Adverse infant outcomes include preterm birth, fetal growth restriction, stillbirth, and infant death. With regards to maternal outcomes, opioid use disorder in pregnancy is associated with not only an increased risk in overdose, but also cardiac complications, placental abruption, antepartum hemorrhage, infection, and severe maternal morbidity. As defined by the CDC, severe maternal morbidity includes unexpected outcomes of labor and delivery that can result in significant short or long-term health consequences. The rate of severe maternal morbidity, which is often viewed as a near miss of maternal death, has continued to trend upwards in the United States, increasing about 45% in the last 20 years. Based on previous research, it is estimated that each year, greater than 50,000 women nationally experience an event that is consistent with severe maternal morbidity. Severe maternal morbidity not only poses a significant risk to the health of the mother, but is also associated with adverse outcomes for the infant, including preterm birth, NICU admission, and infant death. To reduce the risk of overdose and improve pregnancy outcomes, opioid agonist treatment with either methadone or buprenorphine is recommended and considered the gold standard. Methadone was the mainstay treatment in the 1960s for maternal opioid use disorder until buprenorphine was approved by the FDA in 2002. Mechanistically, while methadone works as a full mu receptor opioid agonist, buprenorphine functions as a partial agonist at the mu receptor and a full kappa receptor antagonist. This mechanistic difference is what gives buprenorphine a superior safety profile over methadone, which includes a lower risk of respiratory depression. Additionally, from an access perspective, access to methadone can be quite restrictive as it does initially require in-person daily presentation to an opioid treatment facility. Comparatively, outpatient buprenorphine treatment does not have an in-person daily visit requirement. However, despite these treatment options that are available, it is worth noting that at least 50% of pregnant women with opioid use disorder nationwide do not receive any form of treatment. Since its introduction in 2002, buprenorphine has become the dominant medication used to treat opioid use disorder in the United States, largely as a result of state and federal policies. Existing research on buprenorphine use in pregnancy has focused on comparing its clinical outcomes with those of methadone, with two major studies being the Mother Project, a randomized controlled trial that was published in 2010, and a second retrospective observational study that was published in 2022. However, there is limited research examining the impact of buprenorphine treatment versus no treatment on outcomes for mothers and infants. Given that at least 50% of pregnant women with opioid use disorder in the United States do not receive treatment, understanding the extent to which buprenorphine treatment in pregnancy versus no treatment modifies outcomes for both mothers and infants is crucial to guiding public health initiatives and policy for the future. To address this knowledge gap, we conducted a statewide population-based study to test the hypothesis that among pregnant women with opioid use disorder, buprenorphine treatment in pregnancy compared to no treatment improves both maternal and infant outcomes. We performed a retrospective cohort analysis, including maternal-infant dyad data from the TennCare database from 2010 to 2021. Birth and death certificate data were obtained from the Tennessee Office of Vital Records. We included maternal-infant dyads in our study if there was evidence of either a diagnosis of opioid use disorder or evidence of maternal opioid use disorder buprenorphine prescriptions. We excluded dyads from the study where there was evidence of either methadone or non-buprenorphine treatment. We defined our primary cohort as those who were continuously enrolled in TennCare from 20 weeks estimated gestational age to 6 weeks postpartum, which left us with 14,463 maternal-infant dyads, of whom 7,469 were treated with buprenorphine. For the exposure, we assessed for evidence of any buprenorphine prescriptions between 20 weeks estimated gestational age and birth. Supplementary analyses measured the association of number of days supply of buprenorphine as well as average daily dose and timing of treatment. Our primary maternal outcomes for the study—
No, but if it gives
severe maternal morbidity, ICU admission, and maternal death. For our definition of severe maternal morbidity, we defined severe maternal morbidity using the CDC's list of 21 indicators, which included 16 diagnoses and 5 procedures. Diagnoses such as acute renal failure and acute MI and sepsis, and then procedures such as blood transfusion and hysterectomy. At present, neither ACOG or SMFM have endorsed a single comprehensive definition for severe maternal morbidity. However, they do recommend using blood transfusions of 4 or more units of blood and admission of a pregnant or postpartum woman to the ICU to screen for severe maternal morbidity. Our primary infant outcomes for this study included preterm birth, NICU admission, and infant death. For both our maternal and infant outcomes, we assessed for them through 6 weeks postpartum. Our covariates for the study were determined a priori based upon the existing literature and clinical expertise and grouped into the categories here, which include maternal demographics, pregnancy-specific characteristics, maternal infections, and substance use. For the analysis, descriptive statistics were calculated to compare characteristics of maternal-infant dyads and the average percentage of adverse pregnancy outcomes in the group who received buprenorphine treatment compared to the untreated group. We also constructed propensity score weighted logistic regression models with overlap weights to achieve covariate balance, as shown in this left plot here on the right, and examine the association between buprenorphine treatment and adverse outcomes. The propensity score analysis allows for us to estimate the probability or the propensity score of receiving a treatment based on a set of observed characteristics. In this case, the covariates for our study, along with a categorical variable for birth year. Then using the score to match or weight individuals from the treatment and control groups to balance covariates and minimize variance. As you can see on the left plot here, we have included both the unweighted distribution along with the distribution after applying inverse probability of treatment weights and overlap weights, with just so visually the improved balance of covariates after we applied weighting. We ultimately chose overlap weights for our models as they do allow for a better balance of covariates between the treated and untreated groups, and they better account for outliers and extreme values compared to inverse probability of treatment weights. After applying our propensity score analysis, we then created separate weighted logistic regression models for our outcomes and calculated odds ratios from models, and then calculated predicted probabilities of adverse outcomes in the treated and untreated groups by applying these models, varying only if buprenorphine was used. For our results, starting with our descriptive statistics, our study found that among pregnant women who were treated with buprenorphine in the primary cohort, 94.7% identified as non-Hispanic white compared to 2.1% who identified as non-Hispanic Black. By contrast, in the untreated group, 85.5% identified as white compared to 10.2% who identified as Black. Other demographic and pregnancy-specific characteristics were similar between both the treated and untreated groups, including lack of access to early prenatal care and attainment of a high school degree or less. The presence of comorbid substance use, such as smoking, was also similarly elevated in both groups. In examining trends over time, we found that the annual rate of adverse pregnancy outcomes for maternal-infant dyads in our cohort, as shown here in Figure C, increased from 27% to 31.6%. When we break it down further and we look at the rate of composite adverse maternal outcomes, including severe maternal morbidity, ICU admission, and maternal death, we see an increase here in Figure A from 4.9% to 5.6% over time, while the rate of composite adverse infant outcomes, so preterm birth, NICU admission, and infant death, as shown in Figure B, had an increase from 24.5% to 29.7%. Between the treated and untreated groups in our cohort, the percentage of adverse pregnancy outcomes was significantly lower in dyads who were treated with buprenorphine compared to the untreated group, 25.4% versus 30.8%. Specifically, the buprenorphine treatment group had a lower percentage of severe maternal morbidity events, preterm births, and NICU admission. There was no statistically significant difference in ICU admission, maternal death, or infant death between the treatment groups. When stratified by individual severe maternal morbidity indicators, there was a lower percentage of blood transfusions, 1.8% versus 2.4%, hysterectomies, 0.1% versus 0.3%, and pulmonary edema and acute heart failure events, 0.4% compared to 0.8%, between pregnant women who were treated with buprenorphine and those without treatment in our study cohort. After adjusting for our covariates through our propensity score overlap weighting, we did find that dyads treated with buprenorphine for maternal opioid use disorder, as shown in this forest plot here, had a 5.1% lower predicted probability of adverse outcomes. When stratified by individual outcomes, mothers treated with buprenorphine had a 1.2% lower predicted probability of experiencing a severe maternal morbidity event. Infants, on the other hand, had a 1.7% lower predicted probability of NICU admission. Most notably, there was a 5.3% lower predicted probability of preterm birth in infants whose mothers were treated with buprenorphine compared to those who were untreated. Presenting this data a different way and looking at odds ratios, we found that dyads who were treated with buprenorphine had a 23% lower odds of adverse pregnancy outcomes. Looking at individual outcomes, mothers who were treated with buprenorphine had a 20% lower odds of experiencing a severe maternal morbidity event. By comparison, infants of mothers who were treated with buprenorphine had a 12% lower odds of NICU admission and 35% lower odds of preterm birth. Our supplementary analyses do not find that day supply, average daily dose, or timing of treatment modified our results. Overall, we found that buprenorphine treatment was associated with a lower likelihood of adverse pregnancy outcomes for both mothers and infants. Our study has certain limitations, including the lack of randomization, as this was an observational study. We attempted to address this limitation through use of a propensity score analysis. Second, with regards to our exposure, we used filled prescription records for evidence of buprenorphine treatment, but did not observe actual medication administration, which could bias our results. Additionally, aside from the covariates that we used for this study, there may have been other confounding variables unaccounted for. And lastly, there are limits to the generalizability of our study findings as this was performed at the state rather than the national level. In conclusion, our study's findings suggest that buprenorphine treatment is associated with significant improvements in pregnancy outcomes. We found that to prevent one adverse outcome for maternal-infant dyads, the number needed to treat was 20. Compared to previous studies that compared methadone and buprenorphine, we did find a notable decrease in the predicted probability of severe maternal morbidity in dyads who were treated with buprenorphine. However, our most noteworthy finding was with respect to infant outcomes, where we saw a more than 5% reduction in the predicted probability of preterm birth. The rate of preterm birth continues to be a growing issue in the United States, complicating 10.4% of all pregnancies as of 2022. Previous research has also demonstrated an association between opioid use disorder in pregnancy and preterm birth, with some studies reporting rates of preterm birth as high as 20% in pregnant women with opioid use disorder. Consequently, our study's findings demonstrating the association between buprenorphine treatment and lower predicted probability of preterm birth have significant public health implications. Lastly, I'd like to touch on some of the racial disparities that we do see in treatment access. Our study found that pregnant women with opioid use disorder who received buprenorphine treatment were significantly less likely to be Black. Similar trends have been noted in other studies, including a report that came out last year from the Department of Health and Human Services that found that only 18% of Black women received medication for opioid use disorder during pregnancy, compared to 48% of white women. These data highlight the stark need for much more equitable treatment access to close the racial gap in treatment receipt during pregnancy. While efforts have been made at both the state and the national level to increase access to buprenorphine, pregnant women with opioid use disorder continue to face significant structural and social barriers to accessing treatment. Some of these barriers include differential access to treatment, especially in rural areas where we can see access be more limited. Additionally, thinking more broadly about health inequities and social determinants of health, we know that transportation barriers, financial barriers, and housing insecurity also serve as a limit to access to treatment. Additionally, there is good data to show that stigma, guilt, and fear of losing custody also serve as a large barrier. There is variation across states regarding policies surrounding opioid use during pregnancy, with some states having far more punitive policies towards pregnant women with opioid use disorder, and some policies requiring reporting of cases to child welfare, which may dissuade pregnant women from seeking care out of fear of losing custody of their child. And lastly, there are significant barriers pregnant patients face in even obtaining an appointment with an opioid use disorder treatment clinician. Our group had published a secret shopper study back in 2020 that found that pregnant women were 17% less likely to be granted an appointment with a buprenorphine waivered provider compared to a non-pregnant woman. Thinking about these barriers and the results of our study, they all underscore the urgent need for much more treatment expansion nationwide. I want to acknowledge all the members of our study team, in particular our statistician, Elizabeth McNear, for all of her work on the analysis, as well as my mentor, Dr. Stephen Patrick, for all of his guidance, his support, and encouragement over the last few years. Here are our references, and thank you so much again for the opportunity to share our group's work, and I'm happy to take any questions.
Thank you so much, Sunaya. That was an excellent presentation. We appreciate the great work from your group. So we're going to open it up at this point for Q&A. There is one question that came up in the chat about asking about how you handled buprenorphine versus buprenorphine naloxone in this study.
Yes, that is a great question. So we do have a supplement that is attached to our main paper. So we did include both buprenorphine and buprenorphine naloxone. So we've included all the NDC codes for that as well, including also Suboxone and then a couple other buprenorphine prescriptions.
Thank you. I'll open it up. If you have any questions, you feel free to unmute or you can put something in the chat.
I think I see a hand.
I just have a comment. I'm Loretta Finnegan. You probably weren't born when we did this study, but your study is much more sophisticated. But we compared methadone and no treatment and found similar, very, very similar outcomes that you did. In other words, those who had been on methadone, in just one parameter, decreased their incidence of preterm birth from this was a hospital where many of the women had no prenatal care. So the incidence was around 20% versus 48% in those that did not receive methadone. So similar results, but as I said, your study is so much more sophisticated, and thank you for doing it.
Did you see a difference in the addendum between bup and Suboxone?
I don't think that we did compare like the two, like buprenorphine, Suboxone in the end. Just when we were looking and we defined our exposure for buprenorphine, we did include like Suboxone, buprenorphine, naloxone, but we didn't actually differentiate between the two in our final analysis.
The reason I'm asking is that we're seeing less neonatal opioid withdrawal using the combined product at this point.
Right.
I was curious if it changed anything, but okay. Thank you.
Thank you for the question.
Davida, I'll let you speak next.
Thanks. I will make a quick comment on what Jan just said. I think that likely the findings of decreased NOWs with the combined product are confounded by change in NOWs assessment in the same time that we've also transitioned to using the combined product. That being said, it does make sense to sort of study and look at it. I wanted to follow up on Loretta's comment and an opportunity that I feel like you have using this data set, which is really valuable, which is actually to look and add a third group back, which is really the individuals on methadone. So when Loretta did her groundbreaking work earlier, there was only methadone, there was no buprenorphine treatment option. And now clinically, when we really think about who uses methadone versus who uses buprenorphine, we actually think of them as pretty different clinical phenotypes. And so I'd be very curious, given the opportunity that you have in this data set, to actually look at that third group and understand how no treatment, as you've defined it, compares with methadone. And I'm curious if that's something that you did on the side and is part of a different paper or is an opportunity for future research.
Yeah, that's a great question. I think there were a couple reasons as to why we didn't look at methadone specifically. So I think one of the things is that there is a lot of data that's out there, good data, looking at like methadone and no treatment, a lot of good papers that have investigated that. But there is like a pretty large gap looking at like buprenorphine treatment versus no treatment. And as it currently stands right now, in the population in the United States, it really is like 50% or more of pregnant women who don't receive any form of treatment. And we do have a lot more buprenorphine providers compared to methadone providers. The other thing with specifically our data set is that since we're using Tennessee Medicaid data, it actually didn't extend coverage to methadone until like around 2021. So not as many of our patients like in our cohort would have been on methadone. It's also a little bit harder to get data looking at like methadone claims data compared to buprenorphine. So considering all of that, that's why we looked specifically at buprenorphine compared to no treatment. But I definitely think it would be very interesting to look at that other variable as well and just see what we're seeing from methadone versus no treatment. But I think with our data set, we're a little bit more limited on what we can explore from like the methadone component.
That makes sense. Thanks, Sunaya. Mishka?
Yeah, thanks so much for this presentation. And presented it like super well. Like, it's a great paper. I love this paper, but you presented it like so spot on. I just wanted to reflect that back, like, really, really well done. I'm looking, Loretta, for the link for that paper of yours. I love that paper. Because but I can't find it real quick while I do this. I completely agree with Davida to think about other, with this data set, other ways to look at stuff and evaluate some of the questions that have been raised. The thing that I like most about this actually is your use of the number needed to treat, and also your attempt to get at sort of a summary measurement of like morbidity, or adverse events, or however you said it. And that, it makes sense. It's not, as you mentioned, there isn't a definition for this. So one can imagine in the future, we should be working on trying to come up with something, that's shared around that. And so anyway, like that's one direction of this, is like thinking about utilizing that, core assessment across other studies. And that's for us to think about as a group, and, all the people who are here. And the second thing is to really kind of push for this, this classic evidence-based medicine tools, such as number needed to treat. And then in speaking them, I'm wondering, as you have started to, you and Stephen and others have started to speak this, like how, like, like relearning how to speak the number needed to treat. And I presented these data just the other day, and I compared other, numbers needed to treat, and there's lots, but this is a pretty low NNT. And it depends obviously on what the outcome is and stuff like that, but trying to think the one that it's comparable to, both in terms of the size, and is like Chantix and smoking cessation at 6 months. So trying to think about, this is a different project, but thinking about sort of organizing the evidence around numbers needed to treat as a kind of to guide public health, sort of priorities. So I'm really wondering what are next steps, and whether, we've just, detailed some of our suggestions, but I'm curious what you think, good next steps are.
Yeah, absolutely agree with all of those points that were raised, especially with the number needed to treat, which for us was one of the last things we looked at when we were doing analysis, and was really like the big like take home point that was there. So I think now like some of the next steps that we're thinking about are both from like a research and a policy side. So I think this number needed to treat is like a really big number that can stick with a lot of people, especially policymakers. So showing that just it is a really low number that we actually really need to like treat to achieve such big outcomes. And then one of our big results that's there is with regards to preterm birth, where we're seeing like a 5.3% lower predicted probability of preterm birth when mothers with opioid use disorder do receive access to treatment. So presenting this data, getting in the hands of policymakers, and trying to encourage like more change and expansion of treatment options for women with opioid use disorder is one of the big things. I think another thing that we really want to look at from a research perspective is some of the more long-term outcomes for infants and mothers with who receive treatment. There isn't too much data looking at like what are the outcomes for infants as they like grow, as they go to school, and what those actually look like if mothers do receive a buprenorphine treatment. So wanting to look a little bit more at that is one of the next steps for our group and our projects down the road.
Caitlin, such an interesting comparison that you just put in the chat. And gosh, like we throw mag, right, at everybody. So really, really useful. Sunaya, I have one more comment. I will second what Mishka just said. Like your work and your presentation of this work is like really top notch and exceptional. So one of the things that many of you in this room know I've struggled with administrative data, and I'll use Mishka's terminology because I think he's helped me think through this, is a limitation of being actually able to understand untreated addiction versus treated addiction. And you and your team, looking at the paper, defining presence of opioid use disorder from 20 weeks gestation age on to delivery and or 1 OUD inpatient admission is, I think, a different definition than what we've seen in many administrative data papers prior to this. And so I was wondering if you could just share a little bit more about how you were thinking about weeding out the historical OUD claims, which we know carry forward with people, particularly in pregnancy, particularly in that delivery hospitalization. And just because they have an F code doesn't actually mean that they have opioid use disorder that's not in 10 years of remission, right?
Right, yes. That's a very good question. So I think addressing the question from two sides. So first, the definition of the timeline for our cohort. So 20 weeks to 20 weeks estimated gestational age to 6 weeks postpartum was our primary cohort, but we also did do another analysis that we had in our supplement, which was 90 days before delivery to 6 weeks postpartum. So those two choices for like the timeline for our cohort were both for clinical reasons. So 20 weeks to 6 weeks postpartum is thinking more about like duration of treatment and kind of the implications from that. And then the 90 days to 6 weeks postpartum does have implications for one of our outcomes, which is preterm birth. We did have a larger N, of course, when you do have 90 days to 6 weeks postpartum, which was one of the other reasons why we wanted to choose that cohort, but we didn't see like any statistically significant difference in our results when we looked at the two. And then for defining our group, so just like you mentioned, we did look at maternal opioid use disorder, like if they had diagnosis for that, but we also looked for whether there was evidence of maternal opioid use disorder, buprenorphine prescriptions. And then we ended up doing like another analysis as well, where we just looked at those who like had a diagnosis, a maternal opioid use disorder, and then also looked at if they just had like prescriptions that versus if they just had prescriptions that were filled as well to try to tease apart some of that. And I think that is another limitation where it is possible that someone could have like a historical diagnosis of maternal opioid use disorder that's there, and maybe they aren't currently using, and that's just something to consider. But I think when we did look at our claims data that's there was everyone did have at least one claim that was filed for buprenorphine in the group. So we can hope we can try to extrapolate from that they were still like in receiving treatment for it, if that makes sense.
Totally. Just to clarify, I absolutely understand your treated group. It's the untreated group where I
Yeah.
actually wonder if you have some individuals who are in long-standing sustained remission from opioid use disorder maybe were previously on buprenorphine, but are no longer on buprenorphine during their pregnancy or any other MOUD. And so you have them in your untreated group, but actually they're just sustained remission from opioid use disorder and they have a carryover code. And so that would actually make your number needed to treat artificially higher than it may be because you have those sort of sustained remission in your quote untreated addiction group.
I see. Thank you for the clarification. And yes, I think that is a limitation that we do have to consider in this study and something that we just have to like mention and to keep in mind going forward.
Great. Anyone else have any other questions for Sunaya? This is an excellent discussion.
Davida, I think you're like that's spot on. Like we do a bad job of differentiating treated versus untreated, and then we don't, and it's not just two categories. There's the category of recovery, and that can be misclassified as untreated if all you're looking at is MOUD.
Yeah, excellent points. Claims data is really great and to be able to generate the evidence like what was presented today, but it always comes with these caveats, right, that we have to consider when we're considering the implications of this findings, but still very thankful for the evidence that we were able to generate using claims data, especially in the field that we're in. Well, on this Friday, I think we don't have no more questions, but Sunaya, thank you so much for your presentation and for bringing your data to our group. And thank you everyone for coming on this Friday. When this gets posted on the YouTube, I will make sure to send that out, and please feel free to share that with others. And then when I do schedule the next journal club, please, I ask for your help in disseminating that opportunity to your circles to help bring more people and more communities to this journal club going forward. And thank you, everyone, and have a great holiday weekend. We'll see you next time.
Thank you so much again, everyone, for the opportunity to be here today and for all the great feedback as well. Have a good weekend.
Congrats on graduating. Best
Thank you.
wishes.